Welcome to vpod.ai. This deep dive is sponsored by Stonefly, your trusted solution provider and advisor in enterprise storage, backup disaster recovery, hyper-converged VMware, Hyper-V, Proxmox cluster, AI servers, SA365, a turnkey security appliance, public and private cloud. Check out stonefly.com for more info. All right, let's get straight to it. Today we're taking a deep dive into a health topic many of us might not know much about, but one that is profoundly important: ocular melanoma, or as you might call it, eye cancer. Our mission for you today is really to cut through the noise, bring some real clarity to this rare condition, explore what it means for individuals, understand the various treatment paths, and shine a light on the absolutely crucial role of support and ongoing research.
Yeah, and what's truly striking about ocular melanoma is its unique set of challenges, from often silent beginnings right through to the intricate, really personalized approaches needed for treatment. This deep dive should give you a clear, comprehensive understanding of this specific cancer, and you'll see why every step forward in research and, well, every piece of support makes such a vital difference.
Okay, so let's start with the absolute fundamentals. What exactly is ocular melanoma?
Well, in its simplest form, it's a type of cancer that starts in the eye's pigment-producing cells, the ones that, give your eyes their color. Most people think of melanoma on the skin, right? But these same cells exist inside your eye.
Ah,
And most ocular melanomas affect the middle layer of the eye, which is called the uvea.
the uvea.
Exactly. Think of the uvea as having three main parts: the colored part you see, the iris, then a structure around the lens called the ciliary body, and then right at the back of the eye, there's a layer packed with blood vessels called the choroid.
Got it. Iris, ciliary body, choroid.
And interestingly, the choroid is where these tumors most commonly decide to set up shop.
And I guess that challenge of figuring out where it is made even harder by just how incredibly rare this cancer is.
Oh, absolutely. We're talking about roughly 5 to 6 people out of every 1 million each year in places like the US, Canada, and Europe.
Wow, that few.
Yeah. To give you some perspective, it accounts for only about 3 to 5% of all melanoma diagnoses in the US. It's really like finding a needle in a haystack, which, makes early detection even tougher.
Right, because if it's rare, doctors might not think of it first.
Exactly. And because these tumors often form deep within the eye in places you just can't see in a mirror, they typically don't cause any symptoms in their early stages. That's why it's so difficult to notice them.
So if it's not obvious, what should someone be looking out for? What are those maybe subtle clues?
Well, when symptoms do finally appear, they can be pretty varied. You might experience things like flashes of light or floaters, those little specks that seem to drift across your vision.
I know those.
Or some people notice a growing dark spot on their iris, maybe a change in the shape of their pupil, or just poor or blurry vision, usually just in one eye.
Okay.
Other reported signs can include a loss of peripheral vision, that's like not being able to see things out of the corner of your eye, or sometimes a sensation of eye pressure, dryness, even intense headaches.
Headaches too.
Yeah, sometimes. Or maybe a prominent red blood vessel in the eye. Or even something quite startling like a black curtain seemingly covering part of your vision.
Wow.
Often, the first time it's actually caught is during a routine eye exam where your eyes are dilated. That lets the doctor see the back.
So those regular checkups are crucial then.
Absolutely critical. But if you ever experience sudden vision changes, you need to seek emergency medical care straight away. And for any of these other symptoms, definitely make an appointment with a healthcare professional promptly. Don't wait.
That makes perfect sense. So with such a kind of sneaky opponent, what do we actually know about why it happens? What causes this rare cancer to pop up in the first place?
That's the million-dollar question, really. And frankly, the exact cause isn't fully clear. But we do know it involves fundamental changes in the DNA of the eye cells. Think of it like a typo in the cell's instruction manual.
Okay, a typo in the DNA.
Yeah, and these typos lead to uncontrolled growth, which forms a tumor. And unfortunately, if those cancerous cells decide to, travel, that's when we see metastatic cancer.
And are there specific things that put someone more at risk for these typos happening?
Yes, there are some established risk factors. People with lighter eye colors, blue or green eyes, seem to have a slightly higher risk.
Really?
Yeah, and it's also more common in white individuals compared to other races. Your risk also generally increases with age, with the highest incidence happening between 60 and 79 years old.
Okay, age is a factor.
Definitely. And certain inherited skin conditions can play a role, like something called dysplastic nevus syndrome, which causes unusual moles, or ocular melanocytosis, which involves unusual pigmentation on and around the eyelids and more pigment inside the eye itself.
Right.
Some specific genetic changes passed down through families are also factors. And while some research suggests that UV light exposure from the sun and tanning beds might contribute,
The UV light connection.
it's suggested, but it's important for you to know there are currently no known preventative measures for ocular melanoma. We can't say for sure, do this and you won't get it.
That uncertainty must be hard.
Okay.
Which really brings us to the human side of this diagnosis. And these stories, they're just incredibly powerful. Take Melody, for instance.
Yeah.
Her diagnosis began completely out of the blue, didn't it? Just from an eye exam.
Yeah.
Because she broke her glasses.
Incredible, yeah.
And the doctor mentioned ocular melanoma, so casually apparently. And it just left her in complete shock, crying, unable to even process that melanoma could affect the eyes.
Mm.
Her journey really brings home that immediate, raw, emotional impact of a rare cancer diagnosis, that feeling she described of being numb and floating out in space.
Yeah, that's a common feeling.
And what struck me was her initial prognosis.
Yeah.
Only 2 to 5 years to live if the cancer spread. That chilling news fueled not just her fear, but also this deep anger and kind of fierce determination to fight.
Melody's experience really highlights that initial shock, doesn't it? And then there's Sasha's story, which kind of underscores the immense mental toll when the disease is more advanced.
Right. Sasha's story was intense.
For early symptoms, the eye pressure, dryness, headaches, that black curtain vision, they were actually misdiagnosed multiple times before a malignant tumor was finally found.
Oh, wow.
Whoa.
Multiple times.
Yeah. And then she had to undergo emergency eye removal surgery within days. She described the physical recovery as difficult, sure, but said the emotional impact left a deeper scar.
I can only imagine.
And the real punch came later, when routine scans revealed stage 4 ocular melanoma with tumors now in her liver and lungs. It's just a stark reminder of how aggressive this disease can be once it spreads and, the very limited treatment options that exist at that stage. Sasha really emphasizes that, and I quote, "The hardest part isn't always the physical treatment, it's the emotional weight of knowing the disease may never go away."
Gosh, both of these courageous women's stories, they just reveal the sheer shock, the fear, anger, distress that come with this diagnosis.
Mm-hmm.
They spotlight the immense mental toll, the gnawing uncertainty, and how deeply it impacts long-term planning, doesn't it?
Absolutely.
And a powerful takeaway from both, I think, is the absolute necessity of self-advocacy. Sasha especially, she trusted her gut, pushed tirelessly for more opinions.
Which is so important.
Yeah, accessing specialized care far beyond her local offerings through sheer persistence and even, I think, crowdfunding.
Yeah, she did what she had to do. And it's also important for you, the listener, to remember that patients often experience profound, extreme tiredness, what we call fatigue, due to both the cancer itself and the treatment.
Right, not just regular tiredness.
No, this isn't just feeling tired. It can be really debilitating, requiring significant adjustments to their daily life and a constant need to prioritize rest.
So, given these profound personal impacts, let's turn our attention to the path forward. Navigating treatment for ocular melanoma. What are the main goals when someone gets this diagnosis?
Well, the primary goals are always to, first, get control of the cancer in the eye, second, slow its potential spread elsewhere, and third, manage any symptoms the patient is having. This is often referred to as palliative or supportive care, meaning we're really focused on quality of life alongside the cancer treatment itself.
Okay, quality of life is key. And what are the most common ways to treat the cancer when it's still, just in the eye, localized?
For tumors localized to the eye, radiation therapy is probably the most common approach. This can involve something called brachytherapy.
Brachytherapy.
Yeah, which is like placing a tiny radioactive disc or plaque directly onto the outside of the eye right over the tumor to target it with a high, precise dose of radiation.
Okay, like a targeted strike.
Exactly. Then there's proton beam therapy, which uses highly focused energy beams, or another tap called stereotactic radiation therapy, which is also a form of very precise radiation delivery.
And surgery. That common?
Surgery is definitely an option too. It can range from just removing the tumor itself, if possible, to something called enucleation.
Enucleation.
Yep.
That's removal of the eye.
Yes, removal of the entire eye. That's typically reserved for eyes that are severely damaged by the tumor or when there's very extensive growth that can't be saved.
Right.
And sometimes laser therapy, like transpupillary thermotherapy or TTT, is used often as an add-on after brachytherapy to kind of boost its effect.
So it sounds like the treatment plan really shifts depending on where exactly the tumor is and how big it's gotten.
Absolutely. It's very personalized. For example, really small tumors in the choroid, that back layer might just be observed carefully for a while, see if they grow.
Just watch and wait.
Sometimes, yes, if they're tiny and low risk. But larger ones, though, usually require radiation or potentially enucleation. Melanomas in the iris, the colored part, are generally small and slow growing, so they can often be observed or treated with a specific type of surgery to remove just that affected part of the iris, or sometimes radiation.
Right.
If the tumor is in the ciliary body, that structure around the lens, it's typically treated with surgical removal if it's small, or radiation therapy. Enucleation might be needed for more advanced tumors there too.
And what about conjunctival melanomas? You mentioned those are different.
Right, those are on the surface of the eye, the conjunctiva. They tend to be more aggressive. Their main treatment is surgery, often followed by therapies right on the surface to clean up any remaining cells, like cryotherapy, which freezes them, or even topical chemotherapy drops, like mitomycin C.
It's amazing how many different approaches there are. Now, you mentioned proton beam radiation therapy, PBRT. I hear that called the gold standard sometimes for ocular melanomas. Why is that? What
Ooh.
makes it so effective?
Yeah, it often is considered that. The advantages are quite compelling. PBRT offers the lowest overall risk of the tumor coming back locally, right there in the eye. We're talking local control rates of 95% or even higher.
95%? That's impressive.
It really is. And it also has excellent rates of preserving both the eye itself and, crucially, the patient's vision. The physics of the proton beam are key. It's incredibly precise. It delivers a uniform dose right to the tumor with minimal scatter, which means it does a better job protecting critical nearby structures like the optic nerve, the macula essential for sharp central vision, the lens, and the cornea.
So it's like a sniper rifle compared to maybe a shotgun approach.
That's a decent analogy, yes. It's highly targeted.
And how did that procedure actually work? Is it complicated for the patient?
It's a highly sophisticated process, but manageable for the patient. It usually starts with a minor surgery to place tiny, temporary metal markers called tantalum rings on the outside of the eye, right around the tumor's border. These act as guides for the beam.
Okay, like little targets.
Exactly. Then there's a detailed planning phase involving radiation simulation and precise calculations using specialized software like iPlan. The radiation itself is typically delivered over a short period, often just 4 or 5 consecutive days, with powerful, focused daily treatments.
Just 4 or 5 days.
Typically, yes. For example, maybe 56 to 60 gray equivalents, which is the dose measurement, given in 4 fractions or sessions.
And the outcomes look good.
Studies consistently show very high long-term local control rates, over 95% at 5 years, and still around 95% even out to 15 years. That means the tumor doesn't grow back in the treated area.
That's remarkable longevity.
It is. Overall survival at 5 years is approximately 80%, which reflects that risk of metastasis we talked about. And interestingly, from a cost perspective, PBRT has actually been found to be potentially more cost-effective than brachytherapy in some analyses, largely because it often requires only that one initial surgery for the markers, compared to 2 surgeries for placing and then removing the plaque in brachytherapy.
That's fascinating. So PBRT sounds like a really powerful weapon against the initial tumor. But what happens if the cancer does spread or metastasize? We heard in Sasha's story how significant that concern is.
Indeed, it's the critical challenge in this disease. About half of all uveal melanomas will eventually recur somewhere else in the body. And when they do, they most often spread to the liver. We see liver mets in about 90% of cases by the time metastatic disease is found.
90% to the liver. Wow.
Yes. But it can also appear in the lungs and bones. And here's where it gets really tricky. This spread can happen years after the original eye tumor was successfully treated, almost as if it's been silently waiting.
Years later. That must be devastating.
It is. And what's truly disheartening for patients and doctors is that metastatic ocular melanoma is highly resistant to many standard cancer therapies. For instance, those immune checkpoint inhibitors, which have been, revolutionary for skin melanoma.
Yeah, you hear about those a lot.
Unfortunately, they show much less efficacy in uveal melanoma. We just don't see the same response rates.
So if it does spread, particularly to the liver, What are the options then?
Well, for liver metastases, there are what we call locoregional treatments, which means they're focused just on the liver, that specific area. Options might include surgery, if there are only a few tumors the surgeon can safely remove, or radiation targeted to the liver tumors.
Okay.
Doctors might use ablation, which means destroying tumors with focused heat or cold, or they can sometimes inject chemotherapy directly into the liver's blood supply. Another approach is embolization, which tries to cut off the blood supply to the tumor.
Targeting the liver directly.
Right. And then there are systemic treatments, which travel through the whole body via the bloodstream. These include immunotherapy, different types than the checkpoint inhibitors, sometimes targeted drugs, especially for conjunctival melanomas, which can sometimes share genetic weaknesses with skin melanomas, and traditional chemotherapy, although its effectiveness is often limited.
It sounds like this area, metastatic disease,
Mm-hmm.
is where research is really intensely focused. What's happening on the frontiers? What are the most promising clinical trials right now?
Absolutely. There's an enormous unmet need here, particularly for late-stage disease, and the research community is highly active, thankfully. There are some promising clinical trials underway.
Like what?
Well, for example, researchers are testing adjuvant therapies, that means treatments given after the primary tumor is treated, to try and prevent spread. Things like combining immunotherapy drugs, ipilimumab with nivolumab are being tested for high-risk patients to try and stop distant metastasis from ever happening.
Trying to head it off early.
Exactly. There's also a drug called tebentafusp, which is a type of bispecific antibody. Think of it like a guided missile designed to latch onto both the cancer cell and an immune cell, bringing them together to fight. It's shown some encouraging results, like an 18% overall response rate in early studies, which is better than we often see.
Okay, 18% is a start. What else is looking interesting?
Other trials are exploring more sophisticated liver-directed therapies. For example, combining something called yttrium-90 radioembolization, tiny radioactive beads delivered to the liver with systemic immunotherapy. This approach has actually shown some remarkable lasting responses in some patients, even complete responses where the tumors disappear.
Complete responses. That's fantastic news.
It is, though, still in trials. There's also a technique called percutaneous hepatic perfusion, or PHP, using the drug melphalan. This involves temporarily isolating the liver's blood supply and delivering a very high concentration of chemotherapy directly to the liver, much higher than you could tolerate systemically. Retrospective analyses have reported significant response rates, around 47%, and improved one-year survival.
Wow, really flooding the zone, so to speak?
Kinda, yeah, but just in the liver. Beyond that, researchers are digging deeper into novel targeted therapies, looking for specific weaknesses in the cancer cell's signaling pathways, trying to block certain proteins like protein kinase C or focal adhesion kinase, sometimes combined with other inhibitors.
Getting really specific at the molecular level.
Exactly. Understanding the molecular drivers of the disease, what makes it tick at a genetic level, like understanding the role of the BAP1 gene, is absolutely crucial for identifying even more therapeutic opportunities.
And I heard something about zebrafish.
Yes. It sounds strange, but researchers are even using innovative research models like tiny zebrafish for high-throughput screening. They can test lots of potential drugs quickly because zebrafish models are surprisingly useful for large-scale genetic and drug studies.
Zebrafish helping fight eye cancer. Amazing. So we've talked about the disease, the human experience, the treatments, the research. Now let's talk about prognosis. Understanding what lies ahead is so important and, well, it sounds like it's often a tough conversation for this particular cancer.
It is, unfortunately. Uveal melanoma has a significant tendency to spread, which leads to a relatively high mortality rate compared to many other cancers. The stark reality is that approximately half, maybe 50% of all patients diagnosed with uveal melanoma will develop metastases at some point.
Half, even after treatment.
Yes, often years after their initial eye treatment was deemed successful, and somewhat irrespective of the specific treatment they received for the primary tumor.
And once it metastasizes, what does that typically mean for survival time?
The median survival after the cancer has spread is usually estimated at 6 to 12 months, though it's really important to stress that long-term survival has been reported in individual cases, so it's not hopeless. And generally, receiving some form of treatment for the metastasis does lead to a better median survival than having no treatment at all.
Okay, so treatment still matters, even then. This raises a crucial question then. What factors give doctors and patients clues about an individual's prognosis? How do you know who's at higher risk?
There are several factors, and they create a complex picture. First, there are clinical features, things the doctor can see or measure. Generally, older age, being male, and having a larger tumor, both its width, the basal diameter, and its thickness are linked to a less favorable outlook.
Size matters.
It does. Also, if the tumor is located specifically in the ciliary body, that's often associated with the worst prognosis. Or if it has a more diffuse kind of flat growth pattern rather than a lump, that can be more aggressive. And certainly, if the tumor has already grown outside the eye wall, that's a poor sign.
Okay.
Then there's what the pathologist sees under the microscope, the histopathological features. Certain types of cancer cells, called epithelioid cells, are linked to worse prognosis. Also, how fast the cells are dividing the mitotic activity, the size of structures within the cell nucleus, the density of blood vessels within the tumor. All these microscopic details provide crucial clues about how aggressive the tumor might be.
So much information in the cells themselves. And beyond what's visible, you mentioned genetics before. How do the specific genetic changes within the tumor cells play into prognosis?
This is a really critical area, the cytogenetics. The single most important prognostic factor we know of right now is the complete loss of one copy of chromosome 3. We call that monosomy 3.
Monosomy 3. Okay.
That's strongly linked to a high risk of metastasis. Other chromosomal changes, like gaining an extra piece of chromosome 8, especially if it happens alongside monosomy 3, or losses on parts of chromosome 1 or 6, can also point to a poorer outlook.
Are there any genetic changes linked to a better prognosis?
Yes, actually. Conversely, getting an extra piece of chromosome 6, specifically the short arm called 6p, is actually a strong indicator of a good prognosis, a lower risk of spread.
Fascinating. So it cuts both ways.
It does. And building on those chromosome changes, we also now use something called gene expression profiling, or GEP. Think of it as taking a fingerprint of the tumor's overall genetic activity pattern.
A genetic fingerprint.
Exactly. This testing classifies tumors into two main molecular classes. Class I is generally low risk, much less likely to metastasize, and often associated with having two normal copies of chromosome 3, which we call dyssymptomia 3.
Okay, class I is good news.
Relatively speaking, yes. Then there's class 2. This predicts much higher rates of metastasis and is strongly associated with that risky monosomy 3, often found in older patients, with thicker tumors, those aggressive epithelioid cells, and mutations in a key tumor suppressor gene called BAP1.
So GEP testing gives a clearer risk profile.
It gives a much clearer picture of the metastatic risk, yes. It helps guide decisions about how closely patients need to be monitored for spread after their eye treatment.
So after all that really complex information about prognosis and risk factors, what's the single most powerful takeaway for someone listening to this deep dive? What's the bottom line?
What all this complex science really means for you, the listener, is actually quite simple. The single most effective measure we currently have to minimize a poor prognosis is the early detection of ocular melanoma.
Early detection.
Catching the tumor when it's small, before it has had a chance to develop those high-risk features, when it poses the least risk for metastatic disease that is truly your best defense against its deadliest potential. Regular dilated eye exams are key.
Given all these complexities, the difficult treatments, the uncertain prognosis, this raises an important question. How absolutely vital is support and advocacy for someone facing this diagnosis?
Oh, it's absolutely imperative. You cannot overstate its importance. The simple truth, the mantra in the melanoma community is, no one should face a melanoma diagnosis alone. Building a strong, comprehensive network of support is just crucial for both patients and their caregivers, helping them navigate this incredibly difficult journey.
So what kind of support is actually out there for people? Where can they turn?
Thankfully, there's a growing array of support available now. Online communities are invaluable organizations like the Melanoma Research Foundation, the MRF. They offer an online patient forum where people can ask questions, get information, and just connect with others. Ocular Melanoma UK, OMUK, also runs online support groups, including one specifically for people dealing with metastatic uveal melanoma.
So connecting online helps reduce that isolation.
Massively. And beyond forums, many organizations offer structured virtual support groups. For instance, MRF's CREOM initiative partners with Thomas Jefferson University Hospital's Oncology Social Work Program and also Colorado Retina University of Denver COPE to offer virtual groups. These are typically facilitated by licensed social workers in a private, confidential setting. Cancer Care also provides various support groups for patients, caregivers, and even young people affected.
And what about more personalized one-on-one help?
That's incredibly valuable too. For more individualized support, one-on-one peer support can be a real game changer. The MRF partners with a group called Imerman Angels to match patients with mentor angels, people who have truly been there with the same diagnosis.
Talking to someone who gets it.
Exactly. There's also Patient True Talk, which allows patients and caregivers to search for and securely message others with similar diagnoses or treatments based on specific criteria like stage, treatment type, even location.
Wow, that's specific.
Yeah. And for direct questions and navigation, there are nurse and counselor helplines. The MRF, for example, introduces Whitney Baylor, their dedicated oncology nurse navigator, MSN, RN, AONCG, who's available to answer questions about melanoma itself, understanding pathology reports, managing side effects, things like that.
Having a nurse to call sounds amazing.
It really is. The cancer support community also has a helpline staffed by professional counselors and resource specialists. They provide emotional support, information, and referrals in over 200 languages. OMUK in the UK also offers a helpline, and importantly, they provide free psychological support to their members, emphasizing that healthcare teams should be discussing psychological support options and offering what are called holistic needs assessments.
That focus on mental and emotional well-being is so critical. Beyond the emotional support, what about the very practical aspects of just living with this disease day to day?
Yeah, the practical self-care is so important for maintaining quality of life. This includes actively coping with that extreme fatigue we discussed, learning to balance rest with light activity, focusing on good nutrition, and crucially, not being afraid to ask for help from friends and family.
Right, accepting help.
Exactly. Gentle physical activity like walking, Pilates, or yoga can actually help boost energy levels counterintuitively. Finding time for relaxation is key too, through hobbies, learning new things, or maybe complementary therapies like massage, aromatherapy, or mindfulness techniques. And of course, working on improving sleep habits is fundamental.
And what about the practicalities like work or financial concerns? That must weigh heavily on people.
Hugely. Many patients are able to continue working, perhaps with adjustments, and it's important for you to know that employers, certainly in many countries, are legally obligated to make reasonable accommodations. Organizations like Macmillan Cancer Support in the UK and similar groups elsewhere offer practical help with navigating things like applying for benefits or financial assistance if needed.
That practical help is essential. And finally, what about advocating for yourself within the healthcare system? How does that work?
That's absolutely critical. Your care for ocular melanoma should be managed by a multidisciplinary team, an MDT. That includes ophthalmologists, oncologists, radiologists, pathologists, specialist nurses.
A whole team?
A whole team. You should have a named key worker, often the clinical nurse specialist or CNS, who serves as your primary point of contact. It's incredibly important to feel empowered to ask questions about tests, about treatment options, potential side effects, what support services are available through the hospital or clinic. Don't hesitate.
Write questions down beforehand.
Definitely a good idea. And always consider bringing a trusted family member or friend to your appointments. They can offer support, help listen, take notes, and remember information that might feel overwhelming in the moment. Be your own best advocate.
We've certainly journeyed through a really complex landscape today with ocular melanoma. From its subtle, often unseen beginnings, right through to the cutting edge of treatments, and highlighting that absolutely crucial role of personal advocacy and community support. It's a powerful reminder, isn't it, of both the challenges and the remarkable resilience of the human spirit.
It truly is. And this really raises an important question as we look forward. How do we continue to empower individuals facing this rare disease? How do we ensure that these incredible advancements happening in research, combined with the profound power of human connection and support networks, actually lead to even more significant breakthroughs? And just as importantly, how do we create a more compassionate, well-supported path for everyone involved? The ongoing dedication we see in the scientific community, paired with the sheer resilience of patients and their networks, is truly inspiring and, I believe, holds the key to a brighter future.
Absolutely. Well said. Before we wrap up, just a final message from our sponsor. This deep dive has been brought to you by Stonefly. And as a special offer just for our listeners, Stonefly is currently offering a 100 TB immutable and air-gapped SSO NAS for just $8,995. It's a pretty specific piece of tech, but if that's relevant to you or your organization, you can find more information at stonefly.com.